Hi everybody, welcome to my YouTube channel Dr.Sreenivas Medical Concepts and my FB page Dr. Sreenivas Concepts. This is Dr. Sreenivas, neurologist from Andhra Pradesh, India. I am also the medical author of the book Focused Neurology. Today we are going to talk about a very interesting topic, the clinical evaluation of dementia. The clinical evaluation of dementia. When we approach a case of dementia, a person who's got demented illness, two questions should be in the foremost place. One, what is the cause of dementia? Second, whether there's a treatable cause or not. Because if there's a treatable cause of dementia, it is going to do a lot of good to the patient. So not only the diagnosis, but whether there's a treatable cause of dementia is there or not. But to know the cause or whether there's a treatable cause, we need to evaluate. So bedside the clinical evaluation of dementia, what are the important questions we ask to get a good history, and what are the physical findings we do to get to the cause of dementia. So history, what are the questions we ask in history to get a good cause or the diagnosis of dementia, and what are the physical examination findings. So history, what are the questions we need to ask? If it is a subacute onset with metabolic derangement, then we have to think of hypothyroidism. So history wise, if a person has got a subacute onset with metabolic derangement, it could be hypothyroidism. Elderly person, usually more than 65 years of age, with a slow progressive loss of dementia, we have to consider the possibility of Alzheimer's dementia. A person who was well previously, but then he's developed personality disorders with disinhibition, we need to consider the diagnosis of frontotemporal dementia. And then very interesting is that if a person has got visual hallucinations, they're not real, visual hallucination, as if someone is present or animals are present, visual hallucinations with features of Parkinsonism and rapid eye movement sleep behavior disorder. What is rapid eye movement sleep behavior disorder? In sleep, we have rapid eye movement and non-rapid eye movement. The dreams occur in rapid eye movement. Non-rapid eye movement disorder is a pleasant sleep. Usually there are not, it's not a dreamy phase. So in rapid eye movement phase, there's a rapid eye movement. One. Second, dreams occur in the rapid eye movement phase. And therefore nature has given a good protection in the form of paralyzing all muscles. There is hypotonia or atonia of muscles. And therefore even a person has got dreams in the rapid eye movement phase, he cannot enact the dreams because his muscles are all paralyzed. But in this disorder, that is dementia with Lewy bodies, there is a rapid eye movement sleep behavior disorder. In the rapid eye movement phase, when the dreams occur, there is no paralysis. So they may enact their dreams. So they may enact their dreams and may cause injury to the neighbors or others. So rapid eye movement sleep behavior disorder. Capgras syndrome is also common in dementia with Lewy body disease. What is Capgras syndrome? It's a misidentification syndrome. A familiar person whom they see, they mistake them to be an imposter. So this is Capgras syndrome, again common in dementia with Lewy bodies disease and sensitivity to psychoactive drugs. So a person has got visual hallucinations, Parkinsonism, rapid eye movement sleep behavior disorder, and sensitivity to psychoactive drugs. We have to think the possibility of dementia with Lewy bodies. And if a person has got atherosclerotic risk factors, that is smoking, alcoholism, hypertension, diabetes, hyperlipidemia, with stepwise progression, we have to consider the possibility of vascular dementia. If a person has got rapid progression of dementia, 6 months, perhaps they may not even see their next birthday, that is less than 1 year, with myoclonus, we have to consider the possibility of prion disease. Creutzfeldt-Jakob disease. And if a person has got seizures, it could be because of stroke, especially hemorrhagic stroke or embolic stroke, or it could be because of neoplasms, or if the Alzheimer's dementia starts at a very early age onset Alzheimer's dementia, it can also cause seizures. If a person has got gait disorders, we have to think normal pressure hydrocephalus. The normal pressure hydrocephalus, as the name implies, the pressure is normal because here the absorption is not proportionate to the production of CSF. The absorption by arachnoid villi is slightly lagging behind the production of CSF, and therefore the CSF starts accumulating in the ventricles, especially the front horn of the lateral ventricle, but it occurs at a very slow pace, and therefore the pressure is normal. But it goes and impinges, the front horns of the lateral ventricle goes and impinges on the medial part of the frontal lobe, where we have the leg area, where we have the bladder area, and the immediate memory also is there. So we have dementia, we have gait disturbances, we have urinary incontinence. So gait disturbance, dementia, and urinary incontinence, we have to think of NPH, normal pressure hydrocephalus. And if a person has got history of sexual promiscuity, we have to think of HIV or syphilis presenting as dementia. If there's a history of head injury, especially in the elderly, they might even have forgotten the trivial injury which they have sustained. We have to think of subdural hematoma. Basically, head injury produces two types of hematoma. Extradural hematoma, it is because of the middle meningeal arterial rupture, it is outside the dura, torrential bleed. Immediately we have to call a neurosurgeon and evacuate the hematoma. Second is the subdural hematoma. It can be because of a trivial injury, usually seen in elderly. They might even have forgotten the injury, very trivial injury, but then there's a rupture of the bridging vein, so blood slowly starts trickling in, slowly starts accumulating from the frontal cortex even till the occipital cortex under the dura, so it seeps in nicely. This can go and compress the brain and can cause dementia. It's a treatable form of dementia. So subdural hematoma is a history of head injury. If a person has got psychosis along with dementia, psychosis with seizures, dementia with psychotic manifestations, always we have to think of paraneoplastic limbic encephalitis. And if there's a history of alcohol, it could be malnutrition or thiamine deficiency, vitamin B1 deficiency. Alcoholics do not take food well, especially they are prone to thiamine or B1 deficiency. If a person has got history of vegetarianism, gastric surgery, we have to think of vitamin B12 deficiency. And if there's a family history, especially autosomal dominant type of inheritance, chorea, and then dementia, we have to think of Huntington's chorea. We have to always inquire drug intake. Acetylcholine is supposed to enhance memory. Therefore, we give cholinergic drugs in dementia, especially Alzheimer's dementia. We give rivastigmine, we give donepezil, galantin. All these are all cholinergic drugs. And therefore, when there is a history of anticholinergic drugs, this is definitely going to impair memory. So always we have to inquire history of drug intake, any drugs causing dementia. So these are the pertinent questions we need to ask when we approach a person who's got a dementing illness. This is history. Examination wise, what are the findings we classically get? In frontotemporal dementia, because the frontal lobe is involved, they can have axial rigidity, they can have supranuclear gaze palsy, they can have disinhibition, and then they usually amyotrophic lateral sclerosis and frontotemporal dementia also may share the same genetic background, and therefore they may have a mixed picture. The dementia with Lewy bodies, as I said in history, they'll have visual hallucinations, Parkinsonism, and rapid eye movement behavior disorder. Alzheimer's dementia, there will be predominantly memory loss because the hippocampus of the temporal lobe basically gets affected. So they have predominant memory loss. Usually the motor involvement isn't there because it's a corticospinal tract and it is in the frontal lobe. So usually there is not much motor weakness. They have predominant memory loss. They will not have motor weakness. In case if there is motor weakness, it's going to be a very late manifestations. Corticobasal syndrome. Here they have a typical alien limb syndrome. The hand is not under their control, alien limb phenomenon, and they have a pyramidal and prefrontal involvement. Progressive supranuclear palsy, PSP, again they have the unexplained falls, axial rigidity, and the vertical gaze disorders, because the midbrain gets affected. The vertical gaze center is in the midbrain, so they'll have vertical gaze disorders. Creutzfeldt-Jakob disease, they'll have diffuse rigidity and startle sensitive myoclonus, rapid decline in memory, and then a startle sensitive myoclonus and diffuse rigidity. Vascular dementia, vessels are affected, so they'll have hemiparesis or any focal neurological deficit like language involvement, or if the dominant parietal hemisphere gets affected, they can have visuospatial defects. So it depends upon the lobe which is affected. So vascular dementia has either hemiparesis or focal neurological deficit. Then vitamin B12 deficiency, spinal cord gets affected. Vitamin B12 is essential for all myelinated fibers, so spinal cord gets affected, posterior column gets affected, peripheral nerves gets affected, optic nerve can get affected. So these are the features. So vitamin B12 deficiency, myelopathy with peripheral neuropathy. Then we have the hypothyroidism. If a person got hypothyroidism, they'll have dry, cool skin, there will be hair loss, there will be bradycardia. If a person has got vitamin B1 deficiency, Korsakoff psychosis, thiamine deficiency, usually we see in alcoholics or in pregnant lady with vomiting, hyperemesis gravidorum, they present with global confusion, ophthalmoparesis and ataxia. So these are all the important pertinent questions we should ask when we take a good history and the examination. So if we go methodically, we can diagnose, we can know the cause of dementia and then approach accordingly at the bedside itself. So this is the clinical evaluation of dementia at the bedside. I hope you have enjoyed listening to my lecture. If you have any suggestions or comments, kindly post on to my YouTube channel. But please like and subscribe my YouTube channel, Dr. Sreenivas Medical Concepts, and my FB page, Dr. Sreenivas Concepts. Thank you. Bye.